All right, so while the panelists are getting their microphones set up, I just want to say how excited I am to be a part of this panel. Because by way of background, you heard from me earlier, I'm Professor Fazal Khan here at the law school, and I focus on healthcare law and policy. But the past several years, I've been focusing on the use of automation technology, such as artificial intelligence, natural language processing, to deliver healthcare. And some of the kind of legal and policy implications of using this technology. In this past year, I was in DC. I was a visiting research fellow at ARC, which is Agency for Healthcare Research and Quality. And they've been really focusing on, well, how do we use this technology, such as clinical decision support programs, which can augment the ability of providers to deliver more specialized care or primary care in underserved communities, how they can fund different research projects aimed at natural language processing, so you can extract meaning from, say, natural text, also get better voice recognition technology. So these are the things that are kind of percolating, at the highest levels. The VA, the Veterans Affairs Administration, they're very focused on technology solutions because they're also kind of under-resourced in a lot of areas. And of course, a lot of these, new ideas have applications to rural healthcare, which are also facing, as we heard today, a lot of issues with access. So with that background, I just want to briefly introduce our panelists, and when I ask you to kind of give your first initial thoughts, just tell me a little bit more also about your institution, organization, and kind of the big ideas that are possible right now. And the second go around, I want you to kind of put on your futurist cap and say, okay, maybe the technology is not there now, maybe the policy and the reimbursements aren't there now, but what might happen in, say, 5 to 10 years? So first, starting at the far end, we have McCormick, who's the president and CEO of Eagle Telemedicine. Next to him, we have Beth NeSmith, who's a chair in the Department of Physiological and Technological Nursing at Augusta University. T. Faircloth, who's the CEO of Coordinated Care. And last but not least, we have Robin Rao, who's the CEO of Miller County Hospital. So let's start with you, Robin. What are kind of some of the big ideas that you see that are possible now to address some of the challenges in rural healthcare?
Well, my story is probably a bit different than everybody else's that you heard earlier today, which, I'll talk a little bit about that later on, I guess. But I think, the reality that this is my opinion, the reality that I see in rural Georgia and probably in a lot of America is, whether we like it or not, despite some of our best efforts, healthcare as we know it today simply is not going to survive. Now, the public pushes back from that. We all fight against it. But the truth of the matter is, it's not tenable the way that it's structured today. And so we've been going through changes. I've been doing healthcare since I got out of undergraduate school, which I will not tell you how long ago that was, but it was a good long time ago. And healthcare morphs constantly. It is one of the most moving obstacles that there is, in my mind. And hospital CEOs are probably some of our worst enemies. We're always crying, the sky is falling, the sky is falling, the sky is falling. Well, here I am, all these years later, undisclosed, all these years later, and I'm still fighting the same game. And so what I'm saying is that it is going to continue to evolve, it's going to continue to morph, and there is technology out there to help, probably, if it isn't the help that we're looking for, it is the Achilles heel or the factor that is now driving healthcare. Just the technology in and of itself. So some of the technology that I am looking at and embracing is, okay, so if my hospital, for example, does not survive all of this, which I don't believe will happen, I think we'll be one of the survivors. But if we don't survive, what happens in my community if I were to go away? Or if healthcare becomes more of a challenge for me, what else can I do in my community utilizing the technology that's available today to maybe create still some semblance of a sustainable healthcare system? So I look at ambulance systems, I look at telehealth, all the technology that's available through telehealth, and the fact that we can convert ambulances basically into mobile hospitals, or at least sustainable technology, or technology to get patients from point A to point B if I wasn't there. I can also look at something that we're working on right now, which is remote telehealth from a distant place. One organization is several hours away from me that has a lot of well-insured individuals. It's working with industry and trying to figure out how can I bring patients into my community virtually to try and sustain a healthcare system that otherwise may not survive. That's something that I'm looking at doing in terms of forward thinking and what's my next step. Truthfully, I almost don't need a next step today because I have more work than I can deal with. But I'm always thinking about, but what if? And how do I make all of that technology work well for me? So I don't know if that answered your question.
No, that is great.
But that's what I'm saying.
I think it gives us a good framing perspective of, what is possible, right, with the technology out there, but there's a lot of more components, not just technology, it's process and it's people. And then T, I just wanted to hear your thoughts.
Yeah, and so I'm with CCI, and we work with tertiary and rural hospitals to provide them with profitable patients. So we're working with the Swingbed program initially, and technology, as I see it, just there's so many differences between what works in urban areas and what works in rural areas. Just this week we were working with Tammy Mims down at Jeff Davis, and the fact that they don't have cellular service in much of their hospital was a huge factor that I didn't think of, being sort of based in Atlanta. That was not something we really considered, but now it's how do we come up with workarounds with that? So what we're really trying to do is understand both sides of the equation on both how tertiary hospitals look at it, how rural hospitals look at it, and how do we help them work together to bridge that gap, because as I mentioned in the last panel, there are plenty of areas where tertiary and rural hospitals can work together, where tertiary hospitals save money, rural hospitals make money, and it's better care for the patient. So that's really what we're trying to be focused.
And could you expand upon the concept of swing beds? I know it's a term of art that a lot of people here know, but maybe some don't.
Basically, swing beds provide subacute care in rural hospitals. It was actually started in Utah in the 1960s. In 1980, it became a national program, and it provides nursing home level care, but in reality, your readmission rates, which Tony mentioned last time, your readmission rates are 1/3 that of a typical SNF. And for the rural hospitals, especially for the critical access hospitals, it's a revenue generation that works, because the way, newsflash, healthcare could be so complicated. But the way that critical access hospitals are reimbursed, they lose money on every acute care patient, but they make money on their subacute patients. But what happened from a rural hospital's perspective is, as times got tough, you can control your subacute patients, you can't control your acute care patients. So they cut the profitable patients but kept the money losers, and that just puts you in a death spiral. So what we're trying to do is work with them to create more, all patients are good, but good revenue generating patients, and have appropriate, like Samantha mentioned, the right level of care for the right patient at the right place, and that's what we're trying to generate.
Yeah, and SNF is skilled nursing facilities.
Oh, sorry.
I can see you spent time in D.C. Beth, what are your thoughts?
Yeah, great. So I'm Beth, NeSmith. I'm one of the department chairs in the College of Nursing at Augusta University. The more we say it, I think the more people might remember. We are committed, where this is concerned, to providing nurses as kind of that gap, and not only nurses as you might think of them as the bedside providers, but also nurses as advanced care providers. In my department, we educate. We have the Doctorate of Nursing Practice program. We have about 200 enrollees in that program. We graduate about that many every year. It's an incredibly popular program, and nurses, advanced practice nurses, are providing the care in rural hospitals. We want them to provide more care. They're trained for that care. These models have worked in places like Nebraska and the Midwest, and they are trained. They can provide hospitalist care. They can provide great care from a swingbed perspective. We have another program that we're trying to get off the ground. We're trying to get funding for it, we call it the NPEP program. It's Nurse Practitioners as Emergency Providers. And we have collaborated with the physicians in the Department of Emergency Medicine to train the nurse practitioners to provide the emergency level care and to partner with the rural hospitals so that we can help them keep their patients. The nurse practitioners would be embedded in the rural hospitals, provide care with the emergency medicine physicians on the other side of the telehealth or telemedicine portal. And when there's need, the nurse practitioner in the emergency department can keep that patient in the rural hospital and just collaborate with the physicians at the tertiary care. So that's the partnership that was kind of talked about in the earlier panel that we see really working. And it can save money because the salaries in general are about 1/3 less than the physician salaries. And so with that, there's a huge saving. So you might be more familiar with family nurse practitioners who are trained cradle to grave to provide primary care. There's a role for them, particularly for that. And then there's the acute care nurse practitioners who many are not aware. They can do a lot of the acute care, acute procedural things that people in the hospital can do, like input lines and that kind of thing. So there's a role for all of those individuals, and they are doctorally prepared for practice. So we at Augusta University are committed as a through portal to helping solve and help contribute to the solutions to the rural healthcare crisis.
Okay, thank you, Dr. Just to give context so you'll know where I come from, I lead a physician group. Our physician practice is delivered exclusively remotely using telemedicine tools and processes. So we partner with hospitals. Our focus is primarily on the inpatient. It's certainly not the only place that telemedicine can be engaged in the healthcare continuum, but our focus has been on partnering with hospitals to bring physician care to their community to augment and support the foundational care team of doctors and nurse practitioners and nurses on the ground, how we complement and supplement either with specialty services, I think someone mentioned about like ID, or hospitalist care, or we partner with hospitals that have nurse practitioners as their hospitalist, and we provide the clinical backup and support for them and help cover the time frames when they might not be available. So the context that we've seen over the past 10 years is that by bringing physician resources to community hospitals and rural hospitals that can complement and support, add things that they need that they don't have, and help support and round out services and service lines that they do, is that we've been able to see our partners be able to keep patients in their community and satisfy the patients and the families who want to get their care close to home. Effectively, for cognitive skills, is bring the doctor to the patient instead of sending the patient to the doctor. And so by using that, the tools that are there, and I don't think of telemedicine as a separate practice. I just think telemedicine is medicine. We're just using physicians to help support doctors and nurses, nurse practitioners to bring care to the place where it's needed. I think back in the early comments this morning, getting what they need, where they need to get it, when they need it. And so from what we're seeing is that there's immense opportunities to be able to support our hospitals and patients in their community, build on the foundational care team that's already there, and just supplement and add to that. And so that's kind of the context that we're coming from. I think that there's great opportunities. I know that many of you are already doing things in that area, and I applaud that. Sometimes I think when we think telemedicine, we think it's really a big technology thing. And quite honestly, I think the technology is sort of the easy part of incorporating telemedicine. I think that the culture, I think, the patients in the community, hospital leadership and administration, clinical leadership on the ground, I think that changing the way we do things is probably the harder part than figuring out the technology. I appreciate, in some places where they don't have cell signal or broadband, it is actually a technology challenge or a barrier. But most places, I think it's less of a technology barrier than it's a cultural barrier. And so I think that's where the hard work is in selling to the community, though I find the patients are the easiest sell. I find the doctors and hospital leaders are the hardest sell. But if we can collectively kind of open our minds there, I think that it provides many opportunities. Not all of them are needed everywhere, but I think it provides many opportunities.
Yeah, that's a great point. Look at a lot of literature looking at how innovations are diffused. It's not just about the technology. A lot of it's about issues relating to, say, social acceptability of this new technology, whether the culture is willing to accept it. Early last week, I was at University of Pittsburgh Medical Center giving a talk on automation in healthcare, and ironically, at the exact same moment I was giving my talk on automation, people popped up in people's newsfeed. There's an Uber car that ran over someone in Arizona. And of course, Pittsburgh is one of the big testing sites. So everyone's like, so did you hear about the Uber thing? I'm like, when did it happen? Like right now? I'm like, so that goes to social acceptability, right? And what Uber has done, and Waymo, all these other kind of car companies are trying to have automated mobility, they always have a human driver in the front. And they're not necessarily driving, but the main reason they have it there is to reassure the passengers in the back that there is someone there, right? And you look at other technologies such as Google Glass. There's nothing wrong with the Google Glass technology. People are just creeped out by it, right? So it failed to really diffuse because of lack of social acceptability. So taking up Mac's point, turning to you, Robin, is there anything that can be done to maybe kind of address kind of the resistance to kind of these new models of delivery?
I'm probably the wrong person to ask that question of because my approach is probably a little bit more direct than other people. When I'm reflecting back at the prior panel's discussion, and when I was first asked to join the Hospital Authority of Miller County, first question that they asked, and I think about this weekly probably, is they asked me, can I help? And my answer to them was, only if you're willing to change. And you have to recognize that you're a 25-bed hospital in a county of 6,000 people. And there simply aren't enough covered lives here to support the system, which is getting back to my prior comment. That's what we're seeing around America, I believe. Certainly in rural Georgia, that's the challenge. And you heard everybody in the previous panel talk about the exact same thing. So when you ask, how do you change that thought process? You have to just forge forward. I mean, that's my approach. I'm going to do things. I'm a CEO of a hospital. My responsibility is not just to the hospital as a CEO, but to a system and to a community. So my approach is going to be a little bit different and than probably some other people. Anyway, I think that technology is truly a driving force for us. It certainly has a lot of challenges, my God. An electronic health record is a wonderful thing, as it was all presented to us, which, by the way, goes back to Bill Clinton, not Barack Obama. But the thought of it is a wonderful ideal, but in practicality, it hasn't worked for us, and in reality, it has truly hurt us in rural America and also in the tertiary care facilities. We have an issue with physician staffing. What did the electronic health record do? It drove physicians back out of the workforce. So some of this technology is helpful, some of it is hurtful.
T?
Well, one of the things I think, kind of just in my experience with Georgia is that, the rural hospitals are sort of getting a bad rap. I've had nothing but, people realize that, that there's a problem and things have to change. And we've had tremendous enthusiastic acceptance from the rural CEOs. The tertiary centers are a little slower moving because they're sort of the large aircraft carrier, whereas, especially as a rural CEO, you have the chance to impact your hospital at a far greater rate than any tertiary CEO, because you're a whole lot more nimble and they're moving their way and you can turn quickly and make things work. But really on the rural side, I've seen like great willingness to accept because, as they say in Silicon Valley, there's a hair on fire problem, and a hair on fire problem means that if their hair is on fire and you hand them a brick, that's better than the current state, and they will put their hair out with the brick. It may not be the best solution, but it's a whole lot better than your hair on fire. So I've seen a lot of willingness to embrace, and I know Beth's been around the state and talked with a lot of people, and people realize that things have to change, that the status quo and, but this is the way that we do things, that just doesn't work anymore.
Yeah,
so.
We are very committed to changing the culture. It has to happen at the beginning where providers are trained, right? And that's what we do in the College of Nursing. Nurses have always been interested in public health, which I see as rural health in the community health. We started with the visiting nurses, frontier nurses kinds of things. And we in the College of Nursing have ended up applying for and receiving nearly $3 million in HRSA grants to take rural care, nursing care into the rural communities and to do things like primary care and behavioral health and to teach nurses and advanced practice nurses that this care has to happen in the community. So not only are we interested in this nurse practitioners as emergency providers in the rural care area, but we're interested in providing behavioral health and helping those communities. I grew up professionally in a tertiary care center. I'm a trauma nurse, level 1 trauma center. I saw where people were injured out in the community and they came to us. And I was one of those individuals who had to refer them back to Swingbed so that people could get reimbursed. So I've seen it from that tertiary side, but I also get it now from the college, the academic perspective, that nurses go out in the community and we have to save those communities from the perspective of allowing patients to stay or supporting systems that help patients stay in their communities, because that's where they are healthy, they get healthy and they become healthy if we can support that cultural change.
Yeah, I think your point is that the old models don't always work, and I even like the perspective that there's always an old model that didn't work and it evolved to something else that did work, and I think that's where we are, and with our group and our partnerships, everything we have is because that we partner with hospitals on is because the old model didn't work. My dad is family medicine trained, I'm internal medicine trained, but he was in a small community in New Mexico, practiced his entire practice. There were no ED docs. If his patient showed up at the ED, he went to the ED. There were no hospitalists. If his patient was admitted, he was their hospitalist. And that model worked great for his career. He did everything, family medicine, delivered the babies, did the surgery. It was, the quintessential family medicine practice, of the 50s in a small community. But that model, there's not very many people that will and can do that model anymore. There's not very many systems that support that model of care anymore. And so, things have changed and those models evolved. And so I think that the models of care, looking at that quintessential family practice medicine doctor to do everything, that's not the model that's working now, and it's certainly not the model that's going to work into the future. But I think the good part is that there are models. I think that, and we will come up with new ones. We're always evolving, but I think that's, to me, that doesn't need to be depressing that the old models don't work. To me, I think that it's exciting because now we can create and define new models. And I know as leaders, you know, you have to lead organizations and you cast visions, you know, of how the future can be different. Because, you know, to me it seems like the healthcare always, you know, changes or evolves based upon a vision or based upon a crisis. And, you know, and if you don't solve it with a vision, then you or your successor gets to solve it in a crisis. So, you know, I support the vision part. That's a lot better time to address things. But by having a vision of how you can bring specialty care, where in the past you had to recruit a doctor, and then you had to recruit like 2 or 3 of them so you could share call. So you had to recruit doctors to come physically be in a community. But now, you know, you can have a vision and you can have a reality of maybe, you know, either having a specialty that you could never afford or having support for a single physician that can now make an appropriate practice and not be on 24/7, 365. So you can place a vision of we're going to have this specialty, or we're going to expand a specialty, or we're going to add it. We're going to use nurse practitioners with some physician clinical support when they need it to be able to do things that the previous models, you know, now no longer work for. So I think that just as much as it's a great time of challenge, I think that for those who are already, you know, doing that, and from some of the panel members who are already, you know, creating new ways and solving problems in ways we haven't done before, I think that that gives us opportunity. So to me, I like to see the challenge and try to figure the opportunity that it has because we are going to have to do things differently, and we are, and you wouldn't be here today if you weren't already.
Yeah, I mean, speaking of the future and new kind of models of delivery, everyone's probably heard of Amazon kind of announcing its intention to move into healthcare space, right, teaming up with Berkshire Hathaway, Warren Buffett, and Jamie Dimon, JP Morgan, Chase Stanley, whatever they're called. And if you look at kind of, you know, the convergence of what they bring, you know, Amazon's obviously big on kind of big data, analytics, distribution, warehouses, retail everywhere. They filed for pharmacy wholesale distributor license in a lot of states, so they're moving heavy into this area, right? And then, you know, Berkshire Hathaway, you know, some people say, well, you know, they're involved in insurance, and I don't think that's really what it is. I think what it is, it's the JP Morgan and Berkshire Hathaway bring capital. It brings capital plus technology to kind of change the way that healthcare might be delivered, right? The current labor models. Then you see these other big players, right? CVS and Aetna coming together, trying to come together as a hedge against this Amazon model. And then Walmart, right, announced that, you know, they're in talks with Humana. So I just want to get your thoughts about these other developments outside the traditional healthcare provider space. How do you see yourselves interacting with the futures of CVS, Aetna, Walmart, Humana, Amazon, whatever that's going to be?
Well, let me just say, I think Amazon is the big bear at your back door. I really think that. You know, we're seeing, we all know about the healthcare models between hospitals and the mergers, et cetera. But what we're seeing now in the insurance atmosphere is something totally, totally different. I mean, it's predicted right now. I mean, Amazon is going to potentially take over the entire pharmaceutical market, which for me is a tremendous threat. So I'll be watching this very, very closely. Let me back up just a second and talk to you a little bit about who we are and what we do. County of 6,000 people when I first went to Miller County Hospital 10 years ago. Bad debt rate of 18% when I first went there. Multi-million-dollar losses, year after year after year, borrowed money just to pay payroll, to pay pharmaceutical expense, to buy laboratory reagents, whatever it was. And the typical American household was epitomized our hospital. Absolutely upside down mortgage, $9 million in negative equity, $100,000, less than $100,000 in the bank when I first walked in. some of the things that we did were immediately going to case management of our employees, of our patients that came into the emergency room. We talked about Medicaid expansion. Well, you know, one of the first things that we did is recognize that it wasn't going to happen. Even if it did happen, it was not going to be tenable regardless. So some of the things that we did was to try and manage. Now imagine, today we all hear the term of population health. I'm talking about 9 years ago, starting to manage the health care of our population. Not necessarily because they needed management in my, you know, from a healthcare perspective back then, but it was a financial incentive for me. And then quickly I realized that it was the right thing to do as well. So managing the health care of our population, doing case management, opening up a retail pharmacy, doing 340B medications, things of that nature. I turned 2 rural health clinics into free care clinics in 2 communities that we work in. And why? To mitigate some of the healthcare issues that we had and the influx of payers into our emergency room. Some of this we were able to do via telehealth. So we brought that technology on years ago in some semblance, not to the fullest capacity that it could be utilized, but it certainly made some inroads for us. We also use, and Beth talked about the School of Nursing at Augusta University, we also eliminated physicians in our emergency room, and 50% of our medical staffing in our ED is nurse practitioners. The other 50% is PAs. You know, we've got telehealth connectivity with CHOA. We're now an affiliated teaching center with Augusta University. So technology afforded us a tremendous amount of things that we did. The other piece I want to just mention before I do shut up is we listened to people talk about our communities are small. How do we work with tertiary care hospitals? They don't want to work with us. Another key to our success was figuring out what their Achilles heel was and figuring out that they needed us and making them understand how we could be utilized. So when I made that flip comment a few minutes ago about I really need more patients, I have more patients than I can deal with right now, well, that's an absolute truth. You know, we don't have a spare bed in anything that we own or operate. So our problem is one of success. And utilizing an electronic health record, while it had problems and issues, utilizing and integrating it throughout everything that we own and operate, utilizing telehealth where I needed help with psychiatry, huge issue. Help with behavioral and substance abuse, huge issues. Telehealth was there for us. So this technology is, I mean, it can offer some tremendous solutions. Our subacute care program, I tend to disagree with you in one aspect. The subacute care program for us is probably the most successful and profitable line of business that we actually have. So yeah, it doesn't work necessarily in a PPS hospital,
right.
but the technology and all of the other things, I mean, they should be embraced.
Yeah. And it sounds like you're ahead of the curve in kind of implementing, you know, what now people call accountable care organizations, dealing with some of these issues up front.
Well, and we operate an ACO as well, so yeah.
Yeah.
T? Well, one of the things, Robin, she's sort of the sexy rural CEO in Georgia, and everybody's.
Thank you so much. I'm still not telling you my age.
But I mean, everybody's like, oh, she's doing so many different things. But what I think she found that others, like the lesson that others should be learning from Robin, is she figured out what worked for her county. I think you have the second poorest county in what number is it?
Yeah, it's 4th.
Number 4, the 4th poorest county in the state. But she figured out, here are my competitive advantages. She said, you know, what are these guys' Achilles heels? How can I fit in here? as far as the Amazon, Berkshire, all that, to paraphrase Andy Slavitt, it said, anytime providers start acting like corporations instead of providers of care, that's not good for the healthcare system. I mean, it's going to continue to happen. I think as rural providers, you said they should be scared they're coming, but I'd be a whole lot more worried if I were McKesson and some of the other players. They'll be there, but by the time they get there, you have fair warning, and now it's how do you position yourself so you're as strong as possible, so when there's that knock on the door, you're a decision maker rather than a decision taker. And how are you there where you're negotiating from a position of strength rather than a position of need? So it's going to happen. And I don't think it's the end of the independent, rural hospital, but it's probably going to be the death knell of the independent, weak rural hospital. So, get ready, because it's coming in a number of years. Rural health is not the first place they'll attack. There's plenty of other places like McKesson that I'd be really worried in, but they'll be there eventually. So be strong when they're going to get there.
Yeah,
so.
Exactly, which is why we in the College of Nursing actually opened a Walmart clinic, a few years ago. So we had nurse practitioners kind of running that. I know, right, thank you. We did that, and then now in July, we're getting ready to open a nurse-managed clinic where we are. So it's completely nurse-managed, and we'll be billing for ourselves. We'll provide primary care, behavioral health services, like you mentioned. And then the other thing, to your point, T, is if you have to be on the cutting edge to position yourself to be a policymaker versus a respondent, right? And so our strategic plan has included, we were talking about a minute ago, including technology in the curriculum, in every curriculum, in the bedside nurse curriculum, in the advanced practice curriculum. Mac and I were talking a minute ago about how to train nurses from the beginning so that they're familiar and comfortable with and can enter into a care providing entity feeling extremely comfortable with the technology that's coming out there and being ready to manage and handle what it needs to occur, what bandwidth we were talking about and that kind of thing. Just second nature from the ground up in terms of their training. So that's in our strategic plan.
I think and I hope that the foundation of healthcare is always going to be the caregivers, the doctors, the nurse practitioners, the PAs, the nurses, that's going to always be the foundation. I think, as in healthcare, I think most of us, revere that, and that hopefully whatever changes happen, that's still the foundation. But I think that if we focus that's where the foundation is how do you use the technology, not just in the hospital, but in skilled nursing facilities, in home care, in outpatient care. How do you use those to transform all of the health care in the community that you're responsible for? I think that's where the future goes, and whether it's partially driven by corporations and investments that they may make, whether it's new models of hospitals like micro hospitals that maybe are about the same size as what you need, but there may be a different way from an efficiency and a focus in those, but using different environments, but still having the focus on the doctors and the nurses and the providers on the ground as being part of that. I think that what we see with some of these is that we can change the environment. We can, I look for the day that my primary care doctor will let me do my, quarterly visits, from my office on the computer in front of my desk, instead of me driving, 30 minutes to sit in his waiting room and then go through that whole process that I've done, tens of thousands of times as a provider and a few times as a patient, but I look for that day that's there. I mean, the technology's there. It's not for lack of technology. It's in Atlanta, so it's not for lack of bandwidth. It's just lack of the system. And I'll pay a higher copay, for the convenience, So, I mean, it could happen tomorrow. It won't be tomorrow, but maybe someday. So I view that, you know, physicians, doctors, nurses, providers, we can do more things, and it really is right now more limited by, you know, imagination and inertia, you know, than it is by the lack of technology. So I think that there's a place there, and whether it's in the clinics and you know, like CHOA and some of those things that you mentioned, whether it's through those kind of partnerships, but been able to do there. And I think the other thing that transforms it is the scalability. You know, 20 years ago, you had to get physicians or nurse practitioners or PAs came in units of one. You know, you had to hire one, or maybe you had to hire 2 or 3, because that's what it took to provide a service line. But using some of these tools and processes, effectively you're able to get fractional physicians. If you need 1/10 of an ID doctor, well, you can get 1/10 of an ID doctor, and 9 other people, you know, are getting 1/10 of an ID doctor, and now all 10 of you have an ID doctor. But you are doing it, you know, across the county or across the state or across the country. And so from an economy of scale, it gives you opportunities to get services that wouldn't make sense if you had to buy them in a unit of one. You know, and we talked about, you know, earlier about, you know, just kind of the fair market value of hiring that physician. So it just gives opportunities that can be engaged to bring more care to our patients closer to home, maybe in their office, but more care closer to home, and just by using the tools that are either available or shortly becoming available.
Yeah, I mean, that's a great observation that, you know, a lot of these newer delivery models you're talking about are already feasible from a technology standpoint, but really maybe it's staying in the way are issues with kind of the culture of practice, the training, lack of familiarity, regulations, kind of scope of practice, licensing laws, and also reimbursement policy, right? It's going to play a big role as well in order to incentivize these new types of delivery models. But I want to open up discussion to the audience, as I'm sure, you know, your brains are probably, you know, ticking with all the great ideas that are talked up here. Any questions for the panelists about kind of new ideas of how to deal with, you know, challenges in access and delivery of care?
Recognize that in terms of our curriculum and teaching the nurses and making sure that they're trained to to talk about more of the chronic health issues. I think we were talking about that earlier, to make sure that they are trained to do that and that they understand the etiology of those things and how they're ready, because exactly, I mean, that is most of the population right now, so where the nurses are being trained to make sure that they're able to manage that.
Let me say one other thing. You know, I have almost gone back to like in the 1970s when we started doing home visits. So we were doing home visits back then. We've recognized through chronic care management that that's an integral part to what it is that we do in terms of our own survivability. But the technology, and we didn't mention this, look, you know, I'm not going to tell you how old I am. You know, I'm fairly savvy. I can use a smartphone. But there are limitations for me, okay? But there is technology out there that connects the patient in their home with a caregiver. You know, we've got a nurse line where people can call in and do things of that nature. So where our rural health clinic would only be open 10 hours a day, it's now virtually open 24 hours with a nurse. But there is technology through all of this that is so surpassed and makes me feel ridiculously ignorant. And that technology is coming, you know, the younger people get it. They're much more savvy, but that technology is out there for the individual as well that brings that patient right to the...
Robin, you mentioned something that One of the other things we're trying to focus on is the training of a nurse navigator, and that's the person who kind of manages those chronic illnesses, so that we have a program, a clinical nurse leader program, and those individuals are master's prepared. Then we're giving them clinical experiences where they can go out and follow a patient, not just an episode, right, but across their health care, so that they're better managed. And some of those readmission rates that you guys were talking about earlier can be decreased through that healthcare model.
Exactly.
On the other end of that,
Government, is it the carrot or the stick in a lot of this? And the government uses both. But there is now reimbursement out there that encourages us to morph our organizations into preventative care. That's something fairly new. And so through our ACO, it is about cost reduction. But let me just say, whether you want to run an ACO or a hospital, one of the ingredients of quality is cost reduction and cost containment. And shouldn't we be doing that anyway? At the end of the day, should we have ever, I shouldn't say this, but should we have ever been paid and reimbursed when we removed the wrong limb on a person? So, I mean, that's a stark reminder of how our healthcare system was. Now there's the carrot and the stick. So prevention is as critical today, whether you're in a critical access hospital, a rural hospital, or a tertiary care hospital. Prevention is absolutely key.
Yeah, Bill.
Dr. McCormick, I wanted to ask you a question. I know for some of us, everybody's at different levels of learning, but would you take a moment and just, because it may not be clear to everybody, when you talk about at Eagle Telemedicine providing a suite of different specialists, from nephrologists to cardiologists to hospitalists, it may not be immediately apparent how that Roger Forey was talking about, man, I really got to get in the specialist game. We're missing specialists. For a hospital like Rogers, plugging those subspecialists in to back up the local doctors, explain how that works quickly, and then how that impacts that rural hospital's ability to get patients, keep patients, and then frankly, to profit from these patients.
Yeah. Well, certainly what's available, from, whether it's my doctors or other people, because I want it to be broader than that, than just me. But what's available is that physicians can be engaged. It may be 2 or 3 or 4 physicians in a specialty, so that it can, so that team can cover, 24 hours of availability, or there are models where hospitals partner with us that it's on a scheduled next day consult. So if they have a patient that needs an ID, then they do that. And so I think what the fundamental part is that the need can be matched. So if you don't need a lot, but you need a little, then you match, a relationship that provides the little, or it provides it when you need it. So I think that there's mechanisms, in practice models, that get customized to what you need when you need it, whether it's nights or weekends or 24/7 or just scheduled consults, when the need is there. A recent example of a hospital that I know, and I just mentioned because I know them. It's in Kentucky, but it's a rural hospital. They were transferring 10 patients a month for neurology. And for some of you in the room, that may be more than what you're transferring every month. It may be about what you're transferring every month. But because the emergency room physicians and the hospitalist at that practice were uncomfortable keeping patients with strokes and eventually effectively TIAs and a lot of basic neurology, but they were just uncomfortable. And so they wanted a neurologist. And so, so they got 24/7 acute stroke neurology. And the patients that needed clot retrieval were still going to the neuroscience center. The patients that were getting TPA were still going to the neuroscience center, but they cut their neurotransfers within the first month, and it's been sustained from 10 a month to 5 a month. And so 5 patients a month that, it may be an $8,000 DRG, the 12 and the 15s are probably still going, but at an $8,000 DRG, that was real money for them. And it didn't cost them effectively hardly any other resource. I mean, because they already had their nurses, they had the building, all their fixed costs were still their fixed costs. So maybe a little bit of incremental costs, for drugs and laundry and food service. But fundamentally on the same fixed cost structure, they just added 5 patients a month. And those 5 patients who then needed follow-up or then needed PT or OT, or then needed outpatient physical therapy, or then needed a follow-up CT, all of that stuff that comes after that hospitalization, which, as you know, sometimes once you get plugged into a tertiary center, you need another x-ray, you're back to the tertiary center. You need, the therapy, it's back to the so it's not even just the 5 admissions a month, at $8,000 a piece. It's the continuum cycle of a patient now who's plugged in locally, and they wanted to be there locally to begin with. I mean, if they wanted to be elsewhere, they would have driven there. They wanted to be there, but they're able to stay there, and it helps break some of that cycle of once they get someplace, they tend to stay there. So that's kind of what we see. I think that in hospitals, you know what your transfer rates are, you know what you're transferring, and you probably know what things could stay. If it needs a procedure, if it needs, a surgery that you can't do, that's not what you're trying to keep into your community. That's why we have tertiary and quaternary systems. It's great for those things. If you need a cognitive, evaluation, you need somebody to talk to the patient, examine the patient, give an opinion, give a consult, give directions of what comes next. If you need cognitive care, you can do that with telemed, with a physician on the end who, can be available. And that's, from thinking, from, way far, or way high up, that's what you need that physician evaluation. And why ship somebody someplace just to get it?
May I follow up on that, please? I think it's fascinating to me as a former physician.
Yeah.
That neurologist, if he's delivering care in his office, let's say not a hospital
Yeah.
setting, but an outpatient office, he's going to have trained staff who are delegated, doing the number trace diagrams for the neurologist, whatever. How do you set up with telemedicine where you're, I guess, presumably delivering a physician remotely? How do you augment his presence with your available staff to, say, supplement him the way he might do with his office staff?
Yeah. Well, and I may not get everything about your question, but But fundamentally, we believe that that those doctors and nurses on the ground are the key. We're just supplementing and adding. So in the case of like an acute neuro consult, is that example, there's an emergency room physician or a provider that's there. There's nurses in the emergency room. They're engaged with the patient. The patient who's going to be admitted is going to be admitted to a primary care physician, or in most cases these days a hospitalist, who's going to care for them. So everything that's needed almost for the care of that patient is already at the hospital. The one thing that they're missing is that neuro consult. And those hospitalists, we find, they're far more comfortable taking care of a patient with a neuro problem if they've got a neuro consult. And that neuro consult says this patient doesn't need, they don't have the right clinical setting, they don't need clot retrieval. I've checked them, I've seen their CT, they don't need that. You know, they don't qualify, or TPA is not what they need. They don't need that, but what they need is secondary prevention and rehab. Well, the primary care docs, you know, generally are very comfortable with that if they got that stake in the ground. If they have a patient that's coming in with an atrial arrhythmia and they have a cardiologist who's going to be there and evaluate them and tell them what drugs to give them and what to do, they're going to be far more capable and comfortable keeping a patient in the hospital if they've got that cardiologist who's helping them manage the atrial arrhythmia. Whereas if they don't have that, then what's going to happen is almost every cardiology patient's going to get shipped. You know, they may keep a few heart failure patients, but maybe not even the very complicated ones, and especially not if it's on Friday night, you know, or Saturday morning. So, but if they've got a cardiologist there who sees the patient and will come back and see them the next morning, and the next morning until they don't really need them anymore, and then they say, you know, you don't need to come back now. You know, but if they can see them every day, then that can change what they can keep. And so that's what we see is there is that 90+% of what's needed to care for the patient is already there. It's just that one piece that can make a difference. Now, my dad's practice, you know, they hardly transferred any patients. You know, I mean, it was a smaller town, you know, 20,000, you know, and because when I was growing up, I remember it whenever he would come home and talk about that they're sending a patient to Lubbock or to Albuquerque. And that was a rare event, you know. And, you know, and I know some of you in the room that are having, you know, 2 patients a day going someplace every day.
Yeah, and it sounds like that's not really the most efficient model.
Yeah,
right?
and, you know, and if you know, 10%, you know, just 0.2 patients a day, you know, is hundreds of thousands of dollars.
And I just want to briefly intercede. We have time for maybe one quick question or comment. Yes. Go ahead. Yeah.
Well, I have a big question.
Yeah.
Is it possible that the HIPAA privacy laws have gone too far? Because I'll tell you, I took my dog to get surgery at the UGA vet school. I've never had such good care. The vet was communicating with me, the TAs were communicating with me. I knew every bowel movement, every kind of And then my dad was in Athens Regional. I never even talked to a doctor. And so I think that the public is getting this feeling that there's not good health care. And I think it's largely because of these HIPAA privacy rules that every hospital's afraid of breaching. And one, I'm an attorney. It seems to me like you could figure out ways to go around those, to get consents, to get, and you know, I just think it would be so helpful if a nurse was saying, I just checked your dad's blood pressure, it's moving in the right direction, I just gave him his meds,
And you feel like HIPAA stands in the way. Well, that's a very provocative question.
But one of the things is for a lot of like university students, they have the same thing where parents aren't told what their students are. There's more privacy issues, but I wouldn't say that's a HIPAA issue so much as a sort of
Expectation of privacy.
expectation of privacy and a larger societal issue. HIPAA, you know, well, especially like one of the things you mentioned about Amazon, you know, with AWS and now HIPAA compliance, it's easier than ever to have HIPAA compliance. It's not the easiest thing in the world to get, but AWS and you know their different featurings, more and more things are HIPAA compliant. We've got a HIPAA compliant messaging system that, you know, obviates the needs for a fax, which is kind of 20 years too late, but pretty good. But if I could hop on my soapbox, just sort of like why you know, why make changes now? Why does it matter? You know, like with what Mac and what Beth are doing, why should you care? You should care, but importantly for like what Lou said, we've got $60 million in tax credits every year for the next 3 years. That should be huge, and that should allow you to affect, as hospital CEOs, you know, structural changes. How do we move the whole healthcare system into a longer-term, financially viable system? Because right now, what we have is not working. So how do we use, you know, Gary Nelson does an unbelievable job with $4 odd million with the Healthcare Georgia Foundation. Everybody here knows him. He's a giant in this. This is 15 times what Gary's doing every year for the next 3 years. How do we use that to move the rural healthcare system forward so it is sustainable? And just things like Mac's product, things like what Beth's doing, you know, if we work together to make systemic changes to rural healthcare, it can survive. If everybody goes and uses it just to spend, you know, cover operational losses, our long-term outlook isn't good. So how do we use this huge, you know, Dean Burke worked, you know, multiple years to get this thing here, $180 million to try to help start fixing rural healthcare. How do we move in that direction?
Well, thank you. Well, T, you get the last word there, and that's a very big idea we're ending on, and I'm sure we can continue this discussion over lunch, but please join me in thanking the panel for this great discussion.